So I hate needles. I hate needles. I used to like cry and run out. I still cry. I was doing that the nurse always get the nurse that's like, you have a tricky vein today. Like, what? She'll stab me a couple of times with the needle trying to find it. The worst thing you can tell someone is scared of needles. You have a tricky vein. Huh? Tricky got it. How do you okay. One stage. Not as bad as I used to. I was a child. I got over it. I kind of. My uncle still has he's like Vietnam vet and all that. Went through some of the toughest situations, has gotten shot. But when it comes to needles, sure.
If he shuts his eyes and doesn't see the needles, it's still.
No, because he knows it's going.
It still knows it's coming.
I've watched him sit there.
Thank you. I need the one that just has pictures on it.
And just pass out. And he just stick it.
While he's out.
Yeah, while he's out.
No, I need it for
very
smelling.
The funny thing is he has that. He has a whole lot of tattoos.
So those kind of needles.
That's why I am like, go into your back. It takes like the first layers of your skin. Those needles.
Me too.
Yeah, I think it's the mental part. It's like injecting something into that ministry. Hey, that's what you're saying. You know, I'm doing fine. Oh, thank you. Getting all nostalgic. This is the last this commission. This is my first commission I saw all the way through.
Oh, really?
Very much so. Covering your own stuff. Yeah. Sometimes I just first story. Getting that first story written. That's good. You go to the life
Watch your steps. Well, good afternoon. Again, thank you all for being here. I want to begin today by thanking all the members who served on the commission for volunteering their time, attention, and expertise. And I'm going to take just a minute to introduce everyone. So, standing in for Kevin Buchanan is Richard Smotherman, who's the district attorney in Potawatomi and Lincoln County. The district attorney's council was ably represented by Kevin, and we appreciate Richard being here today. Chelsea Church, who's the executive director of the Oklahoma State Board of Pharmacy. To her right is Terry White, commissioner of the Department of Mental Health and Substance Abuse. Representative Tim Downing, District 42. We have Dr. Kevin Taubman, who is the president of the Oklahoma State Medical Association this year. So, Senator A.J. Griffin, and A.J., your district is District 20, mostly Logan County.
Kingfisher, Logan,
Kingfisher
Noble
also,
County.
more than Logan. And John Scully, who's the director of OB&DD, and Lane Sabera, who practices medicine in Skytook. So let's see, Bob Howard is also a member of the commission, an Oklahoma City businessman, and Bob is not here with us this afternoon, and I think that is everybody. So over the past 5 months, we have had 6 meetings. We invited both local and national stakeholders to the table for extensive discussions about how to address the opioid crisis in a decisive way in this state. The presenters brought with them unique views and experiences with their career or with a personal story of how they've been impacted by the epidemic. I want to give a special thanks to the legislative director in the Office of Attorney General, Lori Carter. She helped coordinate the meetings, put the final report together with editorial feedback from commissioners. She was instrumental throughout the course of the commission meetings. Aside from serving as a great attorney in the office, she's also the office's legislative director, and so she'll be integral to our efforts across the street at the Capitol and getting these recommendations turned into law and policy. Thank you again, Lori. And finally, even though they aren't here, I want to thank the Oklahoma House and Senate staff, members in particular, Becky Halliburton, David Krall, and Terry Raymond. During our meetings, they provided technical support, helped us live stream those meetings at the Capitol. They also helped us with transcripts and other meeting notes when we were looking back to finalize our recommendations. Since the Commission's formation in April, I think the members have demonstrated and advocated the need for changes to reverse the nightmarish epidemic in the state of Oklahoma. Nationwide, the opioid crisis has caused the deadliest drug epidemic in United States history. To further illustrate, I'd like to share some data points with you. In 2016, drug overdose deaths in the United States claimed the lives of more than 64,000 people. The jump was the largest increase of overdose deaths ever recorded, and it is, for reference, more soldiers than died in the war in Vietnam. Drug overdose deaths are now the leading cause of death for Americans under 50. If Oklahoma is not ground zero in this epidemic, it is close. In our state, over the last 15 years, drug overdose deaths have increased by 91% and continue to rise. Nearly 1,000 Oklahomans die per year due to drug overdoses. And tragically, in the last 3 years, more than 1,300 newborns have tested positive for substance exposure and went into withdrawal the moment they were born. A presenter at one of our meetings showed us a video of a newborn going through drug withdrawal at the infant's birth. Without a doubt, it was one of the most heartbreaking things I have ever witnessed. Because of the opioid crisis, we're beginning to see an uptick in illicit drugs like fentanyl trafficked into the state, and we're also beginning to see more desperate behavior from addicts. For example, in December, my office charged an Enid nurse's aide for stealing fentanyl patches off the bodies of patients. In response, the Commission set out with the mission to study the scope of the epidemic, the toll it has taken on the state, and identify initiatives, and finally make recommendations to curb the scourge on our state. Our primary focus was law enforcement, the medical community, prevention, treatment, and drug-endangered children. We believe these areas were the most critical and comprehensive. And I now would like to share with you some of our recommendations. There are 31 in total. I'm not going to read them all, but some of the ones that we believe will have an immediate impact are, first, announcement I made this morning, our office, and the Commission is encouraging this, but our office has entered into an agreement with the Department of Mental Health and Substance Abuse Services to participate in their first responder overdose program, which provides naloxone to first responders. For those of you who don't know, naloxone is the opioid overdose reversal drug. It binds to opioid receptors and can reverse and block the effects of other opioids. Saves countless lives each year. So I'm happy to announce this morning I've signed a memorandum of understanding with the Department of Mental Health, and our agents will now receive training and begin carrying naloxone. And I hope our office will serve as the first of many to sign up for this program, Commissioner. Thank you. Further recommendations include mandating the use of e-prescriptions. This is a solution to a very large problem. We saw a presentation during one of our meetings where a presenter actually manufactured a fake prescription using his home computer and a printer. He compared it to a prescription he had written for him by a doctor that he had never filled after a surgery. The two prescriptions side by side were identical. We also believe that the trafficking of fentanyl and its equivalent must be criminalized. Currently, if a drug dealer is pulled over with a pound of fentanyl, there is nothing a law enforcement official can do. The Commission believes that the legislature must pass a Good Samaritan law, that they must require medical clinic owners to register with the Oklahoma Bureau of Narcotics and Dangerous Drugs. To be clear on this one, we're talking about medical clinics owned by individuals who in some cases aren't even doctors. This will allow for better oversight and prevent pill mills. The legislature must fully fund drug courts and other specialty courts around the state. The legislature should review current drug laws to determine drug court eligibility and expand eligibility after the recent changes in the law made some drug possession crimes misdemeanor offenses and not qualified for drug court. This was a oversight from State Question 780 and needs to be corrected. The Commission believes that we should encourage the use of the OD map, OD standing for overdose. That's an application that's used by law enforcement, first responders, and health officials to track overdose events in real time so that resources can be deployed to hotspot areas and criminal investigations conducted if necessary. Commission believes that we should change necessary rules with the appropriate boards to require at least 1 hour of continuing education for all prescribers and pharmacists every reporting period on proper prescribing and the risks of opioids and recognizing addiction and diversion. We're recommending the creation of a statewide emergency department, ER, discharge database to study overdose events and aftercare results. This will allow for better tracking and, similarly to the overdose map, help law enforcement identify hotspots and give us better data. Finally, in an effort to not only identify a problem, but to also provide a solution, the Commission is recommending that the legislature enact a tax on manufacturers, wholesalers, and distributors of opioids, and use the money as a funding mechanism for opioid addiction treatment. Preliminary estimates on a proposed 10% tax could yield anywhere between $14.6 and $17 million a year in revenue for treatment. These are several initiatives we believe can be implemented in the near future and will have an immediate impact. In the recommendation book that you've received, you will see the other initiatives we would also like to see pursued. Again, I want to thank all the commissioners who worked tirelessly on these proposals. And at this time, I'd like to look to the commissioners if any of them have preliminary statements, and then we'll be happy to answer questions. All right, time for questions.
A number of these recommendations are going to require some type of funding. Any idea what the overall cost is going to be if they implement all of these?
Well, the most important challenge going forward as we begin to deal with this is it's an equation that involves supply and demand. And if you don't deal with both sides of that equation, you're not dealing with the problem. So the demand side is addiction. And if the state doesn't invest in getting people well, in helping people get over their addiction, we're not dealing with the problem. So other states in which there's been criminal justice reform and there's been concomitant investment in rehabilitation and treatment have seen very, very positive results. So I think I speak for the Commission in a very emphatic way that there's got to be a priority placed on funding treatment programs, and we haven't just wrung our hands here. We've come up with a remedy that will assist in creating a revenue stream to help get some of this funded. So Bob, why don't you come on in? Bob Howard is, if you will, the civilian member of the Commission. He's an Oklahoma City businessman and was a great contributor in the work we did. Anybody else on revenue?
Agent?
Okay, not everybody at once. In the back?
What is being done to investigate doctors and their overprescribing and tracking that?
So it's a priority of our office, and it's I'm speaking for district attorneys. It's a priority for district attorneys around the state. The conversations that we've had is that we've encouraged referrals. We've worked in a very focused way to develop expertise in our office. We actually have a task force of attorneys and investigators who focus on pill mill activity. So our commitment to the people of the state is when a prescriber, and I say this every time this comes up, by and large, physicians, prescribers are doing everything right for their patients, but there continues to be a minority within a minority who are not being responsible, and we're holding those people accountable, as we did last summer when we charged a Midwest City doctor with 5 counts of second-degree murder.
Is there any way to track those doctors? I mean, track all doctors and their prescribing practices?
There is, and I'd say it's a combination of our efforts in collaboration with the DEA, as well as John and his team. So we have the ability to identify those prescribers who are acting recklessly through different databases that are available. So yeah, when we're provided with evidence that it's going on and it's clear and frankly in the category of reckless, we're acting on it with dispatch.
I'll address the steady one button like to encourage group participation. Tell me something that you didn't know going into this that you now know, something that might have shocked you, something that was surprising to any one of you.
Yeah. Representative?
I think one of the proposals is that we have a limit on first-time prescriptions. One example of that we heard from the dental profession is that sometimes you have a 30-day prescription for someone who's had wisdom teeth pulled. Now that is not what they advocate or train to standard on, but it does occur. It wasn't something that I was aware of, and that was alarming to hear that.
Anyone else?
What is the
Dr. Taubman, and then a question in the back.
I would say, from my perspective, beyond the OSMA, but being a professional medical educator for many years, similar to what Representative Browning brought up, the eye-opening to other fields beyond the allopathic and osteopathic physicians about what the pathways are, that their initial education in pharmacology is, training into what is parallel with what we do in residency or not. There are many individuals in the state who have prescriptive authority beyond what most in the room would consider a typical doctor. And that was eye-opening to us to see the fact of all the levels of education that we get as physicians, and then those who still have the same prescriptive authority, but maybe it's a much different pathway. And so it was interesting to see the fact of maybe how different entry points on the provider side of things have affected this process.
If I could just follow up, I apologize. What do you mean? Who else would have prescriptive authority that you didn't
Well,
realize?
the state of Oklahoma, not necessarily unique to a lot of other states, identifies other individuals beyond an MD or a DO and calls them physicians. So that would be a dentist, a veterinarian, podiatry, chiropractors, optometrists. And these individuals have various levels of prescriptive authority, and some of them even to the degree of Schedule II, which is the opioid narcotics. Their pathways are not the same as it is for a physician necessarily. Some overlap, and then some are actually quite divergent. And it opened our eyes to the thoughts about how we need to go back to the level of education, both for a student, let alone trainees at different points of their process, and start thinking of how we weave that in there even in more detail than what it already exists today, for those that either already have it and need it augmented, or for those that really have a poverty of that education. It needs to be substantially elevated to give them the same level of ability to practice at a high standard.
Dr. Sabera, would you mind talking about medically assisted treatment? It was certainly an eye-opener for me.
One of the issues that I've been interested in is expanding access to medication-assisted treatment, primarily with buprenorphine in our state. Nationally, only about 2% of physicians have taken the special training required to prescribe MAT and treat addiction patients in their office. And I think it's an exciting opportunity that we talked about for our state, because if we can get more buy-in from the physician community on this therapy, we can use existing infrastructure and save a lot of cost to expand therapy for a lot of people that need it.
Good.
Anything else?
Very good. Thanks. Other questions?
how would
In the back and then over here.
How would the e-prescriptions work, and what would it take to get that done?
How about you, Chelsea? Excuse me, or maybe John. How about both of you? You first and then John.
Okay.
Go ahead. Thanks.
With the pharmacies, most all pharmacies now in Oklahoma have the prescribing authority as far as taking the e-prescriptions and coming into the pharmacy. So probably 4% is all that's missing that software. So from pharmacy standpoint, we're ready. The software has to be authenticated by DEA from a provider standpoint, but then the pharmacy can take those scripts now.
I guess I'm a little confused. I happen to know this, or I'm confused because my husband just had me placed for surgery. But when you are given a prescription of Oxy or any opioid, you have to physically go to the doctor to get a written prescription. Is that like that
No, now it would be where you wouldn't walk away with the written script. It would be electronically sent to the pharmacy of your choice, and then they would fill it.
But you still have to go to the doctor's office.
Yes.
So
Yes.
that would change.
Anything to add, John?
No, just that that you have to have a patient-doctor relationship has to be established, and the patient has to visit the physician has to conduct an exam, and then instead of a written prescription, a lot of doctors' offices already do this. So what we're talking about here is trying to mandate that to make that a more general practice within the state. A lot of prescriptions, we investigate a lot of forged prescriptions. Pharmacists are handed forged prescriptions, and e-prescribing, if that takes place, then that should eliminate a lot of the forged prescriptions. There is a lot of work that has to be done on the providers. If they don't have electronic medical records already, if they don't have e-prescribing, there is a cost associated with that. I know that Dr. Sabera can speak to that because he's gone through the process in his practice.
Good. Let's see, Sarah, and then you in the front.
So I had a question about, a couple questions about the tax. I'm curious if you expect any kind of pushback from the manufacturers and distributors, the wholesalers of the opioids. And a question for Commissioner White, will that 14 to 17 million, is that enough money to fully fund the state's drug court program and expand it so all 77 counties have a drug court program?
I'll be stunned, in a word, if there's not pushback. This has been a thoughtful decision-making process. This being trying to identify a revenue stream that is appropriately and narrowly connected to the problem. So I'm sure there'll be pushback, but we're prepared to be as confrontational as we need to be to get this done. Terry?
When you look at the recommendations, there are a handful of recommendations that I think are incredibly important around the need for treatment. And I am actually really grateful to all of the commissioners and the leadership of the Attorney General, because I wasn't the one who was having to make those suggestions or push it. It was clearly understood by everyone on the commission how important this was. And so that was one of the really exciting things about the leadership of the general and the other commissioners. When you look at the specific recommendations, there is a recommendation to fully equip law enforcement with naloxone. There's a recommendation to fully expand drug courts to the capacity and mental health courts to the capacity needed in the state, and to ensure that we invest in treatment. What this step will do under the projected revenue streams, it won't close the entire gap, but it would be able to address the funding for the specialty courts, fully fund the specialty courts, and address the naloxone program, or make a significant step in the treatment direction. But unfortunately, as you all know, there is a huge gap between the number of who need treatment and who can get treatment. But this is a very important first step, and not the only step that the report recommends. The report recommends finding additional funding streams for treatment.
Good. Thank you, Terry. Other questions? You're in the front row. I'm sorry.
I've got a couple questions related to the medication-assisted treatment.
Okay.
For starters, how are you planning to incentivize physicians to participate in that? And Dr. Spera mentioned about that could use some of the existing structures. Is that going to be able to reduce the need to expand state-funded treatment? Or?
Yeah. Wayne, you're on. Okay. And Dr. Taubman, you may have postscript or two.
Well, I think one of the advantages of medication-assisted treatment is that it is designed from the ground up really to be a primary care-based therapy. And so if we can get more doctors interested in prescribing the therapy and more importantly, taking the training course that's required to get the waiver to treat substance use disorder patients with the medication, we can really expand our access, primarily for rural patients too. I've been talking about this topic for a number of years, and when we started out, we only had about 60 physicians in the state who were waived to prescribe the medication. Now I understand we're up to 270, 300, and so we've really increased that capacity. One of the problems with new prescribers, though, is that they're initially limited to 30 patients for the first year, and that's one of the things General Hunter is going to be looking at as far as what type of national influence we can have to maybe raise that 30-patient limit, because that comes from a federal rule. As far as incentives, I don't think we really reached the carrot and the stick kind of balance on that one, but it's really kind of catching on. I know I'm working with the OklahomaMAT.org project, which helps expand therapy in the eastern half of the state and the middle part of the state. And so far we've added on another 20 new clinics, primarily in the east, that will be able to provide this service shortly. So.
Thanks, Dr. Spira. Other questions? Right here, then back to Sarah.
This might be a question for Commissioner White, but
Okay.
on the naloxone program, I know obviously the recommendation is to branch that out to all law enforcement, including homeless shelters as well. Where is that at now?
Sure.
Like, where is it operating?
So in the last 3 years, we have 5,000 law enforcement officers who've been trained through the naloxone program. As you know, that's not all the law enforcement officers in the state. It's estimated there's about 12,000 law enforcement officers, and there's turnover. So as we have new law enforcement officers, we now need to provide the training, but also the funding includes the naloxone kits themselves, which as used need to be replaced.
Okay. In front, and then Sarah.
Could somebody address a bit more about what the Good Samaritan law is, how it will work, what it does, that kind of thing?
Okay. Senator, you're on.
I know this one pretty well since it's been working on it for 4 years.
We can get you.
There is a current Good Samaritan law that addresses individuals that offer assistance in accidents. This is specific, and it's an expansion that allows law enforcement to work with an individual who's placed a 911 call, who has stayed at the scene of an overdose, who provides their name and other answers to other questions to law enforcement. If it protects them from arrest for the possession of drugs, was extremely important in order to get individuals to seek assistance in the time of those overdose deaths. It is waiting, has passed the House several times before, is waiting for hearing in the Senate, and this is a piece of legislation that was actually filed last session. Thanks.
Okay. Sarah.
I'm curious, obviously there's some support from the legislature with representatives here, and this question's kind of on behalf of my colleague, Catherine, who covers the legislative end of things. I'm curious what other support you think you're going to need from the legislature to support some of these things. We've already seen a couple bills, like Senator Griffin's 7-day script limit bill. So I'm curious, do you expect resistance like there was in the prior session?
Representative Downing, you're recognized.
Well, I do think it's important to recognize that Senator Griffin and myself carried the resolution to form the commission, and it was tremendously popular in the legislature. One chamber was unanimous, overwhelming majority in the other. That's important because it shows that they know this is an important issue and they want to find solutions. So the key component of having a commission in the first place, having your Attorney General as the chair of it, having people from all the different medical professions be a part of it, people from law enforcement, that's huge, because the hope is that whatever those recommendations are, when they get proposed as legislation, those entities would not come to the legislature and oppose it. Now, certainly there's different opinions no matter what the profession is, but I think we've worked through a lot of those. That's why we had these meetings. We had a lot of conversations and public meetings to hear a lot of the concerns. And so I think it'll be very positive because the members will see the process that was taken to get to those recommendations. In my personal conversations, it's been very favorable. So.
If I could just follow up with my colleague's question, though, that the tax on manufacturers, wholesalers, distributors, that would be a new tax. That's a 3/4 majority. That threshold has never been met before. Why do you think it'd be met now?
It's never been met. And one thing I think it's important always to recall, now I'm going to take off my commissioner hat and put on my legislator answer here, is State Question 640 allows the legislature to really pass any tax increase as a recommendation to voters. In fact, if you look back, every vote that has failed the 3/4 standard has passed technically, to go on the ballot. So we're very close. The language requires the next general election ballot. We're very close to that. It'd be this November. So at the very least, I think you could see it be placed on the ballot with a majority vote in both chambers. But the other thing I would say is, even as far as reaching the 3/4 vote, I mean, when you look at this proposal, and it's no secret that I haven't voted for a lot of those taxes myself, we have a product that was intended, I think the intentions are for good, and it does do a lot of good when it's used correctly. But that product is resulting in over 1,000 Oklahomans dying per year and thousands more addicted. And so the industry, my hope would be that they see this going on in Oklahoma and across the country, that they would understand they need to come to the table. They need to be a part of providing the treatment for the byproduct of their own product that they're creating. And so I think that, as General Hunter pointed out, it's narrow. This isn't a tax against all pharmaceuticals. It's not a tax against the pharmaceutical industry. It's a tax on the specific product that is causing the deaths of Oklahomans in our state. And we're asking them, please help us fund the treatment for this. Because the alternative is, if you don't attach the stream to the product itself that's causing it, that means you're going to tax somebody else in Oklahoma to foot the bill for this treatment. And that's even more challenging, as you've seen, for the legislature to do that. So I do think that's the right approach. So whether it's through litigation that we're seeing, and maybe we'll be the first state to have that, or whether it's through legislation, I do think that the pharmaceutical industry should help support the funding for the treatment of its own products. So.
You good with that?
Yeah, and let me add one thing. Legislators are people too, and there isn't an Oklahoman left whose family has not been impacted by this problem. And so hopefully, unfortunately, when you have to wait till something reaches crisis, I think even my colleagues across the street understand that we've reached a crisis in our state.
Well said. Will Rogers observed that sometimes an innocent man is sent to Congress. We all need to remember there are innocent people in the state legislature. Sarah.
Clearly the Cherokees are working with their own lawsuit, but I'm curious, are you working with any tribal leaders or Indian Health Services or anybody else as far as these recommendations go to make sure that they're also kind of implemented with Native nations within Indian country?
So now that we have a report, as I think has been described today, there was careful consideration to who the principal stakeholders needed to be to come up with this architecture. And so the next challenges, a set of challenges, is going to be how do we proselytize the rest of the University of Oklahomans who need to be briefed, and we need to deploy to help advocate for this in the legislature. So it's we work closely with the Cherokees. Attorney General of the tribe is a good friend of mine, so they'll be one of the groups that we'll be reaching out to recruit to help us with this. It's a good question. Anybody else before we wrap?
Do you all have a projected date or timeline when you all plan to see results from some of these recommendations?
Well, before sine die, for sure. Getting these recommendations out of the way before you get into the 11th hour of the legislature would be my priority, and that's what I think we're going to be expressing to the Speaker and the Pro Tem. Let's get this stuff done. One more question, two more questions.
This may be kind of off the wall question, or maybe too politically hot, but there is a need, obviously, for pain medication when people have major surgery, that kind of thing. And a lot of people get hooked, like kids after they have wisdom teeth out. That happens. What about, where do you all stand on medical marijuana and its use to treat pain?
So I'll just express my opinion, and what I've tried to communicate with regard to medical marijuana is essentially when this office reviewed the state question, we determined that it is much more expansive than a typical well-regulated, well-supervised medical marijuana law in which there is a doctor who is diagnosing a condition and determining that medical marijuana is responsive to the condition and providing a prescription. So that is, in my judgment, those are the benchmarks for a well-regulated medical marijuana law. And so the state question that proposes legalizing marijuana is much more expansive than that. Doesn't require a prescription, doesn't require a doctor to evaluate somebody's condition. A license issues from a doctor, and then it's sort of laissez-faire with regard to how the cultivation and distribution occurs. So I just want Oklahomans to understand that it's really much more than medical marijuana, and if it's their intention to support a bill that is more recreational marijuana light, that's going to be up to them. But I think experts that I've spoken to will begin to communicate on this and express those same concerns. So again, it's up to Oklahomans, but they need to understand what they're voting on. And in my judgment, I've told the Supreme Court this, I think they made a mistake with not accepting the AG office's redraft. I think our redraft of the title is much more descriptive than what is now going to be the language of the state question. So almost made a clean getaway. Right here, and then we'll wrap up.
So you put together this report. You're going to give that to the legislature, and some of these are also for the agencies. So what happens going forward? Will this commission still continue to meet, see if these recommendations are achieving what you want them to, or how do you?
Well, I'm hopeful that we'll at this juncture we'll begin to turn into advocates as opposed to policy proposers. And so that's my strong expectation that on a regular basis we'll be talking about how we can best get these things turned from policy proposals into law. Okay, one last question.
Quick yes or no for clarification. So the commission did not discuss medical marijuana then, is that correct?
No. No, there was discussion about all sorts of drugs, but I don't want to hotbox anybody up here. I mean, I'm the chairman. I was asked about my position on the state question, and as I've gone around the state, that's what I've tried to tell people: is you need to know what you're voting on.
But the commission did not discuss it, correct?
No.
No.
The answer is no.
Thank you.
All right. Thank you all. Appreciate it very much.
Yeah, that's fine.
Okay. We're adjourned. See you tonight.
I did listen to every word, and that was awesome. Good job. My job stated, yeah.
I think we're going to have a good meal.
Pretty much what everybody thought.
Yeah.
See you this evening.
Appreciate it.